Welcome, everybody. It's 10:04, so I think we'll get started. I'm PJ Naylor. I'm from the School of Exercise Science, Physical and Health Education at the University of Victoria, and I have the great privilege to chair this session. So to begin with, I'd really like to acknowledge, both with respect and gratitude, that we're gathering today on the unceded territories of the Lekwungen people, and specifically the traditional lands of the Songhees Nation. As is shown here today, this is the agenda for the session. We'll start with François Haman and talking about obesity and type 2 diabetes in Northern Canada's remote First Nations community, the dietary dilemma. I'm going to do some introductions right at the beginning of each of them, and then they'll talk without introductions in between. Secondly is going to be Lucie Levesque talking about Indigenous community academic partnerships for physical activity interventions. And then finally we have McComber, who is going to provide you examples of successful diabetes prevention and health promotion programs in Indigenous communities. So to begin with, I'd like to introduce Dr. Haman, who is a professor at the University of Ottawa and a key member of the Indigenous Health Research Group there. I was lucky enough to meet them through a project we're undertaking in Canada. His research targets basic aspects of human nutrition and energetics. He likes to always say, I'm a biologist. He goes from mechanisms to applications. His work aims at establishing the principles that dictate fuel use and provide strategies to improve health using alterations in dietary behaviors or physical training. And his current work is integrating metabolic measurement methodologies to dietary strategies and reducing the prevalence of obesity and obesity-related diseases in First Nations communities across Canada right now, in Ontario and British Columbia, some in the Yukon. Lucie has almost 20 years of experience working with Indigenous community partners. She specializes in physical activity intervention, evaluation, and implementation science, focusing her teaching and research on community-based interventions to enhance physical activity using an ecological approach. And she's a long-term member of the Kahnawake School Diabetes Prevention Program and a frequent collaborator on Indigenous health research, and has extensive experience working with a community-based participatory research framework in Indigenous communities. And finally, McComber, last but not least, is from the Kahnawake School's Diabetes Prevention Project, Kahnawake Mohawk Territory. And for the last 22 years, he's been endeavoring to work on enhancing the well-being of Indigenous peoples and communities across Canada. And as a community researcher, he's involved with Kahnawake School's Diabetes Prevention Program and other national health promotion research initiatives in Indigenous communities across Canada. Alex has extensive experience in diabetes prevention and health promotion, and he has helped with the Kahnawake model for the Code of Research Ethics for that, and I think that contributes also to the Indigenous Code of Research Ethics. So we're really thrilled to be seeing these three speakers, and without further ado, I'm going to turn over to François.
Thank you very much, PJ. So yeah, being a biologist seems to be an excuse. I can use that in all type of situations. So whenever conversation gets too tough, I just say I'm a biologist, and kind of fixes everything. So I'm going to probably create more questions than answer, and then provide answers. And as we go along, you're going to see that the situation within the First Nation communities is amazingly bad in different areas of Canada. But one thing I want to make sure that everybody gets is that we cannot make blanket statements when it comes to food behavior, physical activity, but even situation within communities throughout Canada. Even when it comes to contaminants, I think we have to be amazingly careful about these blanket statements. In the federal government, they love blanket statements because you can develop policy that applies throughout Canada. These communities that I'm going to be focusing on two specific communities in Northern Ontario are 60 kilometers apart, but drastically different. So each community is almost its own entity. And when you go across Canada, and I'm going to show you a few places where we've been, all these communities might be tremendously different depending on leadership, depending on history, depending on the reasons why they're there, depending on food availability, how to get food there. So I just want to make sure that once I'm done my part of the conversation, which will be very very biological in terms, that we don't draw conclusions that will apply throughout Canada. So I'm called Migizi in Oji Cree, and it means bald eagle. And it's mainly because my eyesight, I have 30/20 eyesight, and I can see really far. So yeah, I've been called Migizi up north for years now, and I love that name because bald eagles are pretty cool. So my main field of research, for people that were seeing me present yesterday, I do work on cold exposure and energy metabolism as fundamental gets. So I do substrate kinetics, I use isotopes, and most of these techniques, when you think about First Nation work, you would go, well, they're not compatible. But I use exactly the same methodologies that I would use in the lab in northern communities. And I've actually given courses in the northern communities about thermodynamics 101. So you can actually, by understanding laws of thermodynamics, you can actually understand food systems within the communities. And the advantage with these communities is that the route of entry for food is very clear. You know where the food is coming from, because there's one road, sometimes there's no roads. So it makes it very easy to know where the food is coming from. If you understand energetics, you can understand the solutions when it comes to the obesity crisis. So most of the work that I do will include indirect calorimetry in the lab. I do cold exposure stuff, hypoxia stuff. I look at the effects of diet. And so it's very fundamental work that I do in the lab. And then one day after hockey, that was back 10 years ago, I guess, 11 years ago, I met a buddy of mine, because everything happens after hockey, especially in Ottawa for some reason. And so I met Dr. Robidoux, Michael Robidoux, and Michael's an ethnologist, so there's an H in there, ethnologist. I always call him an entomologist, because I think that's pretty funny. But he's an ethnologist, so he studies culture. He doesn't intervene, so that's what I learned. An anthropologist will intervene and make things better, try to make things better. An ethnologist is just somebody that observes, okay? And you're going to see most of the research that I've done in the communities would have been impossible, even from my perspective, without working with Michael. And when you think about interdisciplinary research, that's as different as you can get two people. He does not add stuff, so I do all the budgets for the grants. He does not add stuff. He's a pure interview type person that will write about his experiences. He makes journals. And we've managed to bring these things together. My first paper with him was in social biology. So this is kind of a good link between these two groups. So Michael has been my guide when it comes to First Nation communities. He's worked 15 years on First Nations hockey. And once he got into the communities, realized how bad the obesity and diabetes problem was. And so he came to me after hockey and said, "Do you want to come work with me in the north?" I was so naive. That was the beginning of my career. And I go, yeah, it's going to be cool, because I had that romantic idea being French-Canadian. You know, I grew up around the Hurons in Quebec City, and for me, it was, oh man, this is amazing. Like, we're going to be kind of going hunting and doing fun stuff, and we did fun stuff, but we also realized how bad the situation was. And I'm going to show you a few reports, and honestly, out of all the work that I do, I could never stop investing energy and time into this project, even though my dean was saying, you need to publish more, you need to get more funding. This is not a link that is linked to science. This is a link that's linked to social importance of the work that we're actually doing. So my contribution to this project is to try to make the communities better. So we are publishing, we're getting books written, we're doing that type of stuff, but our main focus is to actually help the communities. That's our main focus. And for deans and for university administration, it's not always popular. So one thing we have to remember is that, and again, this is across Canada, so we have to be careful because each community might be tremendously different. I've been in communities where the obesity level was not that high and the diabetes level was not that high. But I've been to communities where it was almost 90%. So we're going to talk about 90% obesity communities, but in general, this is the average throughout Canada. So we're talking about 63% of the First Nation individuals, men and women, that are obese or overweight. As a physiologist, I wasn't as concerned about this because I don't know if you guys know, again, I'm going to use the biology thing. As a biologist, obesity or level of fat is a survival index in the animal world. The more obese you are, if an animal's obese, its chances of surviving is increased. So I was concerned about the obesity problem for sure, because it's not, but what I was more concerned about was actually the levels of type 2 diabetes. So the level of type 2 diabetes, and I don't know if there's updated data on this, so if anybody has an idea if there's an updated reference on this, because this is still a bit old, I find. But if you compare non-Aboriginals to Aboriginals, type 2 diabetes occurs at a much younger age. And anybody that has worked with type 2 diabetes, the worst thing that can happen is for type 2 diabetes to happen at very young ages. And if you look at men versus women, women have a higher incidence by far, and it's constantly rising, of type 2 diabetes at age 18 to 29. So what we're used to is my grandmother got diabetes at 85. Okay, and if you know French-Canadian families, it's not because we don't eat sugar, because we live on maple syrup. So essentially, sugar was always part of our life, and my grandmother was obese, but wasn't suffering of type 2 diabetes. The big concern is when you see these values occurring at 18 years old. In one of the communities, I met a little girl of 11 years old that has type 2 diabetes. Okay, so we're dealing with a situation that is dire. And I've actually told the chief in one of the communities, if nothing is done, the kids will die. It's bad. It's not a good situation. Again, talking about two communities that I'll describe to you soon. Some of these values are found throughout Canada in Aboriginal communities. So there's been a lot of data, if you guys are familiar with Eric Ravussin's work, there's been a lot of data measurements done in Pima Indians in the US, but also Aboriginals of Australia. So these situations are throughout the world. Most of the problems are associated to changes in the food system. So the food system has been tremendously disrupted in the First Nation communities. Okay, probably the thing as a parent that probably bugs you the most when you go into the communities is to see the kids. Some of the kids, I'm not going to generalize again. Some of the kids are really suffering from multiple issues, and that's very hard to see. When you see adults suffering from diseases, it's one thing, but when you see kids suffering from the same diseases as adults, it's a different thing. So there was a UNICEF report done, and I kind of always want to use that to kind of exemplify how bad the situation is. So the Aboriginal kids are probably some of the most marginalized children in Canada. They're 2 to 3 times worse off than other Canadian children and are more likely to commit suicide. And as a parent, even those words really hit you hard because, and I've seen situations which I won't describe, but suicide is present in the communities at all times. And that, when you're sending students up to work in these communities, they have to be ready for this. And I can tell you, we are not ready for it. And in some of the communities where we work, what is described here is exactly the situation. And when the children leave the communities to go south or to go to other Canadian communities, they face discrimination, they face racism, they get into isolation, they get into all kinds of things, and people say, yeah, okay, well, that's the way, First Nations are. Well, it's not. We have a humongous responsibility when it comes to that. So some of the causes that have been identified is poverty, lack of education, substandard housing conditions, and that's very obvious when you get into the communities, poor nutrition, lack of access to healthcare and other social services. I would say, again, in some communities, healthcare involves all components of healthcare, meaning mental health care too, and social services are not always present in every community. And one of the things that we, again, I don't know if we forget about it, but it's still extremely present, even though it was in the past. There is a big legacy of the effects of residential schools, and it's still really present in the parenting skills of the grandparents and the parents, and it affects the communities even now. So whatever was done back then has major impacts on what's going on now. So when you go into these communities thinking that I'm going to be talking about carrots and how important it is to eat carrots, and you don't understand these components of it, you're not going to get anywhere. And so that's a very important thing to remember. So part of the solution that the UNICEF provided is that there needs to be culturally appropriate community-based health services. And one thing I can tell you, which is not part of my field at all, is if you don't go in a community with a community-based approach, you will be struggling. You're not there to tell people what to do. You're there to work with people and help them out. You come in as an expert. You come in to be able to provide numbers, and I will provide numbers. And these numbers, by the way, have been provided to communities. We've done a report. You want to talk about KT? We did tons of knowledge translation stuff. And it's central to be part of the community. So we live in the community where we're there. We interact with everybody. It's not to be behind closed doors and just working in the nursing clinic. So that was back in 2012, and as you remember, the Harper government tried to avoid this special envoy from the UN, but I'm just going to focus on one component of it. So basically, he was trying to assess the national food strategy to try to eliminate hunger. And one thing that comes out at the bottom here is that what I've seen in Canada is a system that presents barriers for the poor to access nutritious foods and to tolerate increased inequalities between rich and poor, and Aboriginal and non-Aboriginal peoples. And that is very obvious within the communities. Nothing was done really to kind of solve that situation, so I'm hoping that this will be addressed at one point by the federal government, but this is definitely a situation that resonates with people that work in the North. So even though it was thrown under the carpet, I think this is a very important situation. When you talk to elders, and this was said actually by elders, is before they had access to store-bought food, their health was much better. So people were able to live off the land. They understood the food system much better. And what's amazing with the elders, and I always tell them every time I'm there, because with the elders, they describe energetics, probably, even though they've never taken deep physiology, basic physiology, they can describe energetics as well as anybody in this room. Because a lot of them have lived off the land. And as you know, energetics, when you lived off the land, it's everything. You need to know when to get food, you need to know how to store it. Everything is calories. If you don't have enough calories, you will not survive. And in Northwestern Ontario where we work, and especially that I do cold exposure, which by the way, when I first started, I had an idea of training baby to do cold exposure research up there. But when I saw this situation, I go, this is, in 20 years, maybe I'm going to start doing measurements on cold exposure. But honestly, the problem with diet is much greater. So if you look at it from this scientific perspective, so there's been this study there done by Corden, and it's a very, very good study. And I just want to kind of provide the scientific equivalent of what was said by the elders. So both anthropologists and nutritionists have recognized that the diet of modern-day hunter-gatherers may represent a reference standard for modern human nutrition and a model for defense against diseases of affluence. So the premise when we first started working 10 years ago in these communities was basically this premise, that people could go live on the land, that people could access off-the-land foods and actually sustain a community. Again, that was really naive, because I'm going to show you data to show how difficult that is. And the reason why we know how difficult it is because we went with the people hunting, we went fishing, and we realized how many calories and the cost of these calories, and realized that you cannot sustain a community purely with this method. So this seems like a good strategy, and so this presentation study today will really focus on these food systems. So we put together an Indigenous health group, and that incorporates people in ethnology, biology, sociology, history, toxicology. So I'm going to talk about toxicology. So one thing with going back to land-based foods is really interesting. But if anybody eats a lot of fish, knows that mercury goes up the more fish you eat. And people also know that contaminants are found in the environment. It doesn't mean that store-bought food has no contaminants. But to tell people to go live off the land, or to promote it, you need to understand what that food is bringing into individuals. And I'm going to show you a bit of data linked to contaminants. Our initiatives is to support initiatives that improve access to nutritious foods. So nutritious foods will be two separate things. There's going to be the store-bought food and the off-the-land food. We're going to providing education for better choices throughout life. So we actually did cooking workshops, and it was funny because we did it from my house, and we had the chef from the Governor General's office that actually house that came and did the workshop. So anyway, it's not on the internet, so you guys can't go see it, but it's pretty funny. So I was kind of the host, and I kind of grew up watching cooking shows with my mom, but I didn't do a very good job anyway. It was pretty interesting. So we did 2 cooking shows. We did all kinds of documentation to try to improve the understanding around food. But one thing we really wanted to do, and that's what we've been struggling a little bit with, was to better understand the challenges of food access in different regions of Canada. So it is one thing to tell a community, I'm going to show you some dietary practices, but again, be careful, because 100 kilometers away, they're not on a river system, they're on a lake system, which could be totally different. Where people were nomadic, it was a different situation. When people are not nomadic, and you're stuck into one area, being a hunter-gatherer actually doesn't work with that perspective. You cannot stay in one spot, and reserves actually put people in one spot. So you need to keep in mind that one thing that we're lacking in terms of understanding the food system in First Nation communities is exactly that. Within a reserve system, how do you sustain life? How do you provide nutritious foods? And that has been some of the challenges that we've kind of been looking for. And you know, sometimes acronyms jump to you in the face, and that was kind of a funny acronym that we got from driving back from a conference in Montreal, and we're kind of just trying to find an acronym. And we end up with the BEAVER acronym. So it's benefits, viability, and risks. And within these communities, trapping beaver, anything related to this concept of living off the land will include a concept that the beaver is a very important component of it, because beaver was also the reason why some of the people in Northwestern Ontario ended up in those regions to be able to support the Hudson Bay Company. So they ended up in these regions, they settled to be able to help with the fur trade. So within the benefits, viability, and risk model, which we try to apply in all communities, we're looking at metabolic benefits of food consumption, which is what I do. Cultural revival, which is a very important component. So even though the energy intake might not be that great when it comes to the food that's provided off the land, bringing kids on the land or having people involved in cultural activities is amazingly important. The risks are mainly linked here to environmental contaminants, but one component that I would add to environmental contaminants, is that me? Oh, sorry. One component, it is me. Hello? Can you please shut your phones off? Thank you. So within the risks, there is the environmental contaminants, but one component that we didn't include here, which is very important, is the risk of dying when you're getting on the land. You're ending up in very cold conditions. Some people don't have the equipment to allow them to survive necessarily, and the risks are tremendous. And I'm not going to go through my own experiences, but the risk of dying, let's just say I don't repeat some of the stuff that we've done up north, because the risks were pretty high, and my daughters would be pretty upset by it. When it comes to viability, it's one thing to look at this in a snapshot. And what I'm going to provide to you guys is a snapshot in time. It's going to be in 2007. This is what we measured. But the reality is this is a dynamic system. It's not a static system. So you can provide things at one point, but if they don't translate over decades, then no change will occur. So part of the viability is, what is the knowledge within the community? What is the interest? Because you still have to worry about that, right? You know, you can have all these things that you think that's how you're going to solve obesity and diabetes, but if people have no interest in doing it, then you're kind of wasting your time if you look at it from a community perspective. The economics of living off the land is amazingly important, of living off the land or just providing sustainable food. Availability, sustainability, and land access. And anybody that knows how Government Ontario is operating right now with land access knows how important that is. Because the government wants to tell the First Nation communities to put lines around the areas of the community where they're going to go hunting and fishing, which is not traditional in any way, shape, or form. And the reason why they want to do this is because then everything else is going to be like a Swiss cheese, emmental, you know, with all the holes. And then the mining companies can go in and start mining in the areas that haven't been identified. Okay, so for First Nation communities, and they were told that if they don't do it, the government will do it for them. So we've been heavily funded by different organizations. Some of them include contaminant grants, so with the Environmental Contaminant Program. SHRC, we've been funded by CFI, CIHR, we got MyTax. And I work with PJ on a CACO project, which was funded by the Canadian Partnership Against Cancer. You guys see the link right away? No? Okay. So, but essentially that partnership was trying to implement strategies to improve good quality food within the communities. So we were funded, we had good funding from this organization. We also got funding from the Public Health Agency of Canada. So we started initially, this is Sandy Lake, and you guys might have heard about Sandy Lake. So Sandy Lake is one of the communities that has been identified with probably the highest type 2 diabetes crisis. And there's actually in Canada a lot of documentation on type 2 diabetes when it comes to Sandy Lake. Sandy Lake is a big community compared to the communities I'm going to be talking about. So Sandy Lake is a 3,000 population community. The study that I'm going to be telling you guys about, and I'll come back with this, is number 2 and 3, which is Wapikika and Kasabonika. But these are the main communities that we started working with. And you guys can see Ottawa here. For us to travel to Wapikika and Kasabonika is a 15-hour transit. Okay, because everything goes through Toronto, right? Everything revolves around Toronto. So everything goes through Toronto before you get to Thunder Bay, and then you do the milk run up north. And another community that some people might know about is Moosonee, or Moose Factory, which is a community that we've been very involved in. So this was in Ontario, and as we kept on talking to people and going to conferences, now we're basically across Canada. So we worked with the Inuit of Northern Quebec, or the Inuit of Northern Quebec and the Cree on the hockey program. With Joey Juneau, for people that remember Joey, that played for the Canadians and then the Bruins. And so we basically worked with the youth program, and we provided nutrition programming for him. So we did presentations for him, and then he brought the kids to Ottawa, and we did all kinds of stuff. We're also involved in Northwest Territories, so in 2 communities, Fort Resolution and Fort Providence. We worked in the Yukon, and as we went west, again, not to make blanket statements, we saw things that were amazing in certain communities. And one of these communities that I found tremendous, and I still talk about it every time I get a chance, is Telegraph Creek, which is number 11 here. Telegraph Creek, the community has mobilized itself so much around providing adequate food system that a lot of the issues that we're dealing with in other communities are not present. And if we could use, and unfortunately we didn't get funded in the last CIHR, because CIHR, you know how easy it is to get CIHR, so we didn't get funded in the last CIHR initiative, so we'll keep pushing for it. But Telegraph Creek would have been a very good community to work with to provide strategies to other communities. So when it comes to networking, this was probably the most amazing community I've ever been to. So the study I'm going to describe to you guys today, and one of the big issues when you're looking at obesity, and we focused on this very quickly, and it's not to say that providing physical activity programming is not important in communities, but we are focusing right now 100% on providing nutritious foods, or getting involved in providing nutritious foods. We've been involved in all kinds of stuff when it comes to physical activity. But as a community strategy and research-wise, we focus on nutrition. Because if we cannot fix the nutrition problem, a lot of the other issues won't get fixed. So this is what we focused on. So the study I'm going to be describing to you was done in Wapikika and Kasabonika. And I just thought of something this morning. I just want to describe the logo for Wapikika, and it's going to tell you a lot about what happened during the treaty signing. So treaty number 9 was signed in 1905, and the communities were told, and I'm going to describe this to you because when I got, they actually gave me a little badge. It's not really a badge. It's a, how would you, anyway, some sort of necklace. And I'm going to describe to you what's on that necklace. So you got to remember, and that totally links to the fact of the challenges that we have working on nutrition. A lot of people didn't understand English. So when the treaties were signed, the people that were involved created this. Created this. And what it says is as long as the sun rises, the river flows, so there's a river that flows by Wapikika, the tree grows, they will take care of us. They, meaning the Canadian government. And I guess they did take care of them. And they provided them with food, and that food was the 4 whites: sugar, salt, lard, and flour. That's what they were provided from 1905. So when people, if you get on the reserve, this is what we're going to be providing to you. Okay? So one of the challenges that we have in some of these communities, there is a language barrier when we're talking to individuals. And the way of seeing things, and one of the words that always kind of I found pretty impressive is when you say, you talk to an elder and you say, can you tell me what health means to you? And then, so you're going through a translator. Suddenly you realize that half an hour later, you're getting your answer. And you know what that answer is? Is it to be able to do my work is what health is. So they have no word in Ojibwe for health as we see it, but what they have is to be able to do your work, you have to have all the proper things in place. So it takes forever to describe it. So there's not one single word. So even when you show up, and we like to put health everywhere. So when you show up and you only say that every 5 minutes, it takes you forever when you're doing an interview. Because every time the person says, well, we don't have a word for it. So they keep on going around trying to explain it. So it becomes very difficult. So Wapikika and Kasabanika, we managed to recruit 40 people per community. So in Wapikika, it's a population of 328. In Kasabanika, it's a population of about 800. So it represents 20% of the adults in Wapikika and 15% of the adults in Kasabanika. This is what we found when it comes to the prevalence of obesity. And it was surprising to find within the 40 individuals that we recruited in each community, so we're talking a total of 80, that the obesity prevalence was of 90%, obesity and overweight prevalence. But this was based on BMI. So let's not necessarily take this and compare it to every individual on earth. This was based on BMI. So whether this is directly linked to percent body fat, there's a chance that it is for sure, but at the same time, I think we have to be careful when we're making these comparisons. What is very striking, though, is look at the incidence of type 2 diabetes. And the incidence of type 2 diabetes is as high as 30%, and in women as high as 40%, which to me is amazingly high. And I think for most of you it would be amazingly high. So we're talking 5 to 6 times higher than the Canadian average within these communities. And recently, actually last week, so just to tell you the relationship that we have with the community, I mean, we talk to them at Christmas, we talk to, we're constantly exchanging with them, and one of my good friends there, one of the hunters, just got his foot amputated from type 2 diabetes, and he made tremendous efforts to change his diet. He was diagnosed with type 2 diabetes at 25. Made tremendous changes to change his diet. He was part of the huge abuse, children's abuse, by one of the local priests that abused probably 50 children that were actually reported. And so you can imagine the struggles that he's had. And he made tremendous efforts to improve his diet, but still could not deal with the type 2 diabetes. And he got his foot amputated, which is a huge deal for his lifestyle. So within these communities, a lot of them are flying communities. And if you guys watch Ice Road Truckers, there's actually, in Ice Road Truckers, they go to Trout Lake. Trout Lake is right beside Wapikika. So this is all great when there's actually a good winter and the ice road actually goes. But most of the time, the season is about a month, maybe 2 months, where they can actually put 18-wheelers on that ice. So you get food trucked in during that time, and the cost is tremendous. The other way you're going to get it, so it's either trucking, flying, or you're going to go on the land-based diet. So you can use processed or fresh food, you can grow. So there is a garden now, so we're kind of involved in the garden program, and I'll talk to you guys a little bit about the garden program. And then the community, which is kind of interesting, is this community is a closed community, so you almost see it like a cell. So if you want to be very biological about it, and we have the intake of food, of energy, coming in from this side, which you can quantify, and you have the energy expenditure of the whole community based on demographics. So you can actually make little calculations, which I did at the end, based on a 2,000 kilocalories to 3,000 kilocalorie day, and you're going to see how much land-based food represent. And again, this is not all communities. This is based on values that we got from this community. Okay, so you can actually almost see it like an individual, but it's actually a community individual, and the food is coming in, and you can find out a lot about these foods. With energy balance, right now, looking at the obesity rate, of course, it's a positive energy balance. So it's not a question of lacking food, It's a question of having too much high-density food. Because food is present. If people become obese, based on energy balance, is because there's enough food. But the food quality is amazingly bad. Are you serious? Wow, okay. So within the dietary dilemma, there are 3 areas where you can actually get food. So there's the off-the-land food, there's the healthy food, and then there's the junk food. Of course, you want to try to eliminate junk food and focus on the 2 other types of food. This is the healthy food section in Wapakika. And as you can see, and this is all of it, by the way, so it's good because you can take one picture and get it all. And that includes all the fresh produce that you can actually get. And when it shows up, it's sold within a fraction of a second. What's interesting is that you can get pop at Southern price, but you're going to buy 4 apples for $9. So that makes it a bit challenging for communities to be able to sustain on these types of foods. So what we did is in these communities, try to investigate the effects of wild food consumption on the prevalence of obesity and type 2 diabetes in these First Nation communities. I'm going to talk about dietary markers because one of the issues is getting objective information about what people are eating. And often when it comes to off-the-land food consumption, it tends to be inflated a little bit. A lot of people will say, no, I live off the land. And it was very important for me to get objective measurements of this. So one thing that I used when I was looking at this, so we used interviews, so that was done by the ethnologist, Michael Robidoux. We used food questionnaires. We used 13C and 15 isotopes, fatty acids, and environmental contaminants to be able to determine food consumption. And then how do differences in food consumption affect the prevalence of obesity and type 2 diabetes? So we went for extremes. We tried to get people that eat a lot of off-the-land food and people that eat barely any. So we had 2 groups. We had the group of the low wild food consumers, which are less than once a month, which they do exist in that community, and it's probably the greatest proportion of individuals. And then the high wild food group, which eats wild food twice a week. We took tons of measurements within that study, including all environmental contaminants. We did inflammation in individuals and different markers. The dietary questionnaires did give us an idea about the quality of the food, but as you know, you get almost nothing when it comes to quantity. So we can really use it as a good index of the quantity of the food. Within the semi-structured interview, Michael Robidoux went through the interviews with every individual for an hour and asked them about their dietary habits. And he created, because I asked him, not because he wanted to do it, but he created an index that I could use to compare against biological data. So he created the high wild food group and the low wild food group, and then I tried to confirm that he was right, because I don't really trust him, because he's kind of just telling stories, and I get pretty stressed when he tells stories. So I needed to get an objective measurement about it. So I'm going to have to jump over this, which is kind of, so you're going to have to trust me on this data and ask me questions. I will jump over this, because I'm not going to have time. It's fascinating stuff, though. It's isotope stuff. Awesome. So 13C is linked to the consumption of store-bought food. And the reason is that 13C glucose is only produced by sugarcane and corn sugar, which is not available in the communities if you're eating off the land, but would be available at the store, which is the only source of C13 that you can get. What we saw is between the high wild food group and the low wild food group, there was no difference in C13 levels, meaning that everybody was eating at the store for sure. So they were compensating food consumption from the store. N15 is an index of protein intake. And fish are amazingly high in N15 because they're situated at high levels of the trophic chain. So within the food chain, fish would have a lot of N15. And what you see is N15 is high in the high wild food group and low in low wild food group. So that was indicating that the main difference between the low wild food and the high wild food was fish consumption. So fish consumption was a staple food, and we know it is a staple food within these communities. The best marker of diet between high wild food and low wild food is contaminants. So the high wild food group was more contaminated with mercury than the low wild food group, and was more contaminated with PCBs. So choose your evil. So you got a choice between contaminants or other issues that could come with junk food. Keeping in mind that in the science world right now, even though we can make associations with levels of these contaminants, at the levels we're talking about, it is not an extremely high level compared to Inuit and compared to ocean populations. So you don't want to create a big problem with these numbers. So we had the toxicologists step in and put this into perspective. And this was probably the biggest challenge we had when it came to talking back to the communities, because contaminants would scare people for very good reasons. But what this also shows is that fish consumption was the difference between the high wild food group and the low wild food group. So anybody that knows fish physiology knows that one of the fatty acids that is found in fish is 22,6 EPA, and 22,6 was found in large proportions in the high wild food group and found in lower proportion in the low wild food group. And this is a good fatty acid. So we have all good signs there that people that are eating wild food are actually getting a lot more fish in, and they're actually eating more fish. And this is just another way of looking at it. So if you look at these again are based on the same indices, and you can see that's the index with one of the fatty acid that is only found in the store, goes down as you eat more wild food. And this is 13C, which goes down as you eat more wild food. And then the opposite with 22,6, as you eat more wild food, you get more 22,6. As you eat more wild food, you get more N15. So it basically confirmed that the ethnologist, when he did his interview and created the index, that the values totally matched the science. And we published this in Nature, so Nature Publishing Group. And this is, in my mind, something that we can use as a tool to assess food consumption in more objective manner. But what we found, I know I'm kind of running out of time, but what we found was, even though people had different dietary habits, there was no difference in obesity and type 2 diabetes between the groups. The levels were identical. They were as obese and as diabetic, whether they were on the wild food group or the low wild food group. So you're gonna have to trust me on this. So this just says the same thing. Okay, so now the question is, how much wild food do we need to have any impact on obesity and type 2 diabetes? And these are the maximal level of wild food consumption found around the world, which it is possible to go up to 26 to 35% of food being consumed coming from wild food sources. I made a similar calculation in the two communities where we work, and this is what I found. Based on the food consumption reports, the consumption of wild food from birds, mammals, fish, fruits, and vegetables from the garden represented less than 1% of total energy demand of the community. Multiplied by 10, because maybe we didn't do a good job, we didn't assess it well, multiplied by 10 and you're at 10%. So when it comes to developing a strategy to deal with issues around food, it is important to look at land-based food, but if you want to sustain life within the community, you need to look at store-bought food. You need to improve the quality of store-bought food. So I think part of the efforts, and what we found from these studies, it's extremely important to improve the quality of store-bought food. Doesn't take away from the value of getting on the land and to be able to involve in off-the-land practices, but the cost associated and some of the obstacles that we have within the communities when it comes to getting on the land is the cost. And anybody that goes hunting and fishing knows the cost. It's $5 a liter for gas. That's already quite a bit of money. Knowledge, in one community, there's only 6 hunters, real hunters, because there are other hunters, like the weekend warriors. But the real hunters, there's only 6 of them. There are tons of life factors, and I'm not going to go through all of them because my co-presenters will talk about them. Availability of food, and then you talk about the risk of contaminants. So this, by looking at it this way and be able to identify what people have been consuming, it became very clear to us that the strategy has to be open to looking at store-bought food in these communities as well as off-the-land foods. So yeah, so I'm just going to thank the communities, Shibugama First Nation Council, the nurses, and all the graduate students that have been involved in this project. Thank you.
Thank you. We're just going to move straight to Lucie, and we actually have 20 to 30 minutes to discuss and have a time at the end. So turn it over to Lucie Levesque.
Great. Hello, welcome everyone. Okay, so thank you, François. I think my task here is to actually talk a little bit about the how research is done with Indigenous communities. And so that's kind of some of the background information that, thank you, that François was not able to get into, but that is undoubtedly absolutely essential for him to conduct the research that he does. What am I pressing here? Green? Thanks. Okay, so I'm going to refer to physical activity examples, and so I did want to give you a little bit of a snapshot of the physical activity situation in Indigenous communities across Canada. And again, keeping in mind that yes, there are major differences. These are national data based on two types of surveys. The Regional Health Survey, which is actually data from on-reserve communities, and the Canadian Community Health Survey, which is data from Indigenous peoples that are off reserve. And so if we look at these numbers, and if you're familiar with numbers in the mainstream population, the numbers are quite similar. These are self-reported data, so we know that self-reported data gets us very similar numbers in terms of physical activity this is children and youth. So in youth we see 72% of First Nation children and 65% First Nation youth accumulating at least 60 minutes of reported physical activity. And so we can suspect that that's going to be much, much lower if we had measured data. And then same thing for the next information is in terms of practicing traditional physical activity in communities. We see about 54% of children and 48% of youth who have participated in at least one traditional activity in the past year. So that's not very high. And in the common activities are similar to what we see in the mainstream: walking, running, jogging, swimming, sports. And and again, in the off-reserve communities, also similar numbers: 56% First Nations, 61% Inuit, 51% Métis active self-reported activity. So the picture is similar and perhaps not as dramatically different as the nutrition picture. But those numbers are still pretty bad. And again, assuming that they're much worse if we did measured. So why is that? Well, we know that lifestyles have shifted, and traditionally people lived off the land, and that required a lot more energy expenditure. And so, people hunted, fished, gathered, and it was quite quite expensive in terms of energy expenditure. And now we have a lot of modern conveniences, and that is also true in many, many communities, in Indigenous communities, and both living in remote areas like with the communities that we heard about from François, and also in urban communities where most of Indigenous people in Canada live. And so you could also say that, well, that's true for mainstream Canadians too, right? Where we have now this lifestyle of push-button world and modern conveniences that have made it that we hardly have to lift a finger to do anything. And so we could ask, why should we consider physical activity promotion in a different manner in Indigenous communities? And I think that François alluded to it, but I want to show you a quick, I need to click.
Is it a video?
Yes, the link. Oh, yes. So I just want to show you, it's a quick 2-minute, fast historical picture, and that helps explain why we need to consider physical activity promotion in a different manner when we're talking about promoting physical activity with Indigenous communities. Is that not working? What do you mean? It's a YouTube video. Oh, no, it's YouTube. Well, no, it's not. It's YouTube. All right. Okay, so I guess I'm not going to show it to you. Okay, sorry about that. Yeah. Okay. Well, okay, so essentially, in a nutshell, it said it better than me and in a more pleasant manner, but in a nutshell, the big difference when we're talking about health promotion, physical activity promotion, and why the situation needs to be approached differently is because of colonization and because of the history in Indigenous communities that is still very, very, the effects of which are still very, very prevalent today. And so what that means in a 1-minute history lesson is that when the settlers arrived, everything changed and Christianity was imposed, introduction of alcohol, the capitalism system was introduced, the land was taken away, the Indian Act regulated the entire lives of Indigenous peoples. There was the 60s scoop that you might have heard of, which is, taking children from their families, placing them in residential schools, and maybe some of them returning to their families with, totally removed from their culture and their lifestyle and their language, assuming they were lucky enough to be able to return. So all of this led to loss of culture, loss of tradition, loss of language. And the effects of that are very, very prominent in all the communities today. And to ignore that when you think about working with Indigenous communities is absolutely impossible and unethical. And so that lens needs to be the one through which we approach any types of interventions, any types of research with Indigenous communities. And so from a physical activity perspective, what it means to look through that lens is to say, well, why, for example, are traditional sports and physical activities not being practiced? From 1884 to 1951, ceremonies that involved traditional dancing and activities were banned by the federal government. We had policies even in the 70s that allocated funding to sports like basketball or hockey, but would not fund traditional sports like lacrosse. Okay, so all these things contributed to the shifting away from traditional activities. So, in the past maybe 50 years, we've smartened up a bit, hopefully, and recognized that the importance of physical activity for holistic health, and that means mental, physical, emotional, and spiritual health, and how much sport, physical activity, recreation can feed into all of those dimensions, and how it can be considered powerful medicine. So with that in mind, lots of people have been striving to intervene and promote physical activity, and so that's not only people from communities, but a lot of outsiders too. And I guess this talk is, for people who are outsiders of communities. And we know a lot of stuff from a lot of research done on many different populations, and there's a lot of consensus that probably when we want to promote physical activity, we need to do it from a very multi-layered perspective, an ecological approach that recognizes that there's many layers of influence on physical activity. And so a lot of people probably in this room are on board with consideration for these different layers. And there is not a lot of research with Indigenous communities on these specific factors, but what we do know does lead us to think that yes, there are individual level factors that are important. There's some of the same usual suspects, attitudes, knowledge, confidence for physical activity. When those things are higher, physical activity is more likely. So we want to have a motivated person. We also know that people who have opportunities, and so places to be active, are more likely to be active. And we also know that culturally relevant activities are more likely to engage people. And so All of those layers are the ones that we know of and we would typically try to intervene on from a physical activity perspective. But then when we add the layer of colonization to that and look at it through that lens, that means we need to do things a little bit differently. We need to consider that, yeah, the environment is not necessarily going to be the same, as a lot of François' work showed. We need to consider that at the individual level, that the trauma of colonization and the legacy that that leaves is an extra layer that needs to be intervened on in terms of building a person's confidence towards physical activity. And we need to make sure that activities are going to be relevant and engaging and culturally tied to what's important to that community, so locally relevant. So what do we do? Both from a research and an intervention perspective, what we've done in our work, and I've been working with Alex for over 20 years, mostly in First Nations communities, and but right now we've actually got some projects where we're going to be engaging Inuit and Métis communities. We work from what's being called these days a two-eyed seeing approach, and it's a relatively new term. Essentially what it means is that it's appreciating the perspectives of both the Western, so outside community world, and the Indigenous perspective. And saying that putting those two together is the best way to get a whole picture. And that we each have different ways of knowings that can be appreciated and put to use for the goals that we seek to attain. So from a research perspective, what that means is that when we think from the Indigenous and look from the Indigenous eye, that we're going to draw connections to Mother Earth and recognize that the interconnectedness of people and nature and the environment, that we're going to use the different sources of knowing. We're going to use the approach that of the spirit, the spiritual, mental, physical, and emotional health, and that we're going to strive to achieve balance in order to attain holistic health. An Indigenous perspective is always thinking about the seventh generation, and that's the generation of children that are yet to be born. And so that recognizing that what we do today impacts the future generations, and that to be cognizant of that in every action that we take. It values the subjectivity of what a person's own experience and perceptions. And from a research perspective, that's going to inform how we gather knowledge. It favors alternative methods of knowing that are different from what we would do in a Western model. And it's decolonizing. And again, what that means is this constant recognition of everything being infected by colonization, and that having that at the forefront in everything that we do, both in intervention and in research. From the Western mainstream way, we tend to value objectivity, and we always want to use valid and reliable measures. And that is the dominant model, right? And that's the kind of research that gets published, and that's the kind of research that we read about. So there's definitely a predominance of exposure by all of us to that kind of model in terms of research. So it's important to just acknowledge that and recognize that that just because that's what we're exposed to the most doesn't mean that it's the right way, it's just the dominant way. And that it tends to be colonizing, of course. So I want to just give you I'm not going to go into detail, but just a quick snapshot of what it could mean from a research perspective to marry the two and to have this two-eyed approach. And so here we have an example of the medicine wheel, which is a symbol that is embraced by some, but not all, Indigenous groups. And so what essentially it's a representation of the different, again, the 4 dimensions of health, of the circle of showing that life is continuous and connected, all connected. The different colors represent the different races. And there's different versions of this, but this is one of them. So what we did is we took the medicine wheel and we sort of merged it with the more ecological, the Western representation of this ecological approach, which is also a recognition of interconnectedness of influences in terms of all of our behaviors. And together we created this integrated model that recognizes that at the middle that has the medicine wheel and recognizes the holistic health of the individual, and that is layered by the different ecological levels as we are more familiar with, and surrounded within the culture, so Mother Earth, creation, and all that is known and unknown. So that would be one way of sort of illustrating how we've melded the two in a two-eyed seeing approach. So the other key approach that we use and that François said he could not do without is a community-based, a community-engaged approach is probably even better than community-based. And what that is a collaborative approach to research that equitably involves all the partners and recognizes the unique strengths of each, so again, the two eyes, and that really it puts the community at the heart of it and recognizes the importance of doing good and benefiting the community, as François mentioned, and that is first and foremost. And the research it's not that it's an afterthought, but it is almost takes a second place to benefiting. So why do we use CBPR? Traditional research approaches have failed to eliminate health disparities, and we could go on and on about examples of really bad research done with Indigenous, not with, on Indigenous communities a long time ago, and sadly sometimes even today. Community members are really tired of having research done on them. And so again, a lot of the research has gotten better, and we have, gone from on to for to with, and now moving into by. So research, on Aboriginal people and now by Aboriginal people, and there are increasing numbers of Indigenous scholars in our universities. Community members want research to have concrete positive outcomes. And again, so that is the first question that must be answered when you show up in any community to do research, and that is, how is it going to benefit us? And then mutual trust and respect obviously can result in increased participation in research. And of course, no one is going to answer any of your questions if they don't trust you and respect you and understand that you're doing good, that everything will be of benefit for their community. So the main principles of CBPR, and these are actually drawn from Kirkness and Barnhart, which are Indigenous scholars, and not the traditional principles that we see usually by Barbara Israel, which are very good, but are very, very similar. But I really like this iteration of it, and it's mainly, it really encompasses all of the long lists of principles, which is respect, which is valuing and building on the diverse knowledge of the individual culture and the community, and again, being very specific to the community because they are unique. Relevant, involving the community in all stages of the project to make sure that the research is relevant to needs and dreams of the community. And so here I do want to mention that when you're doing participatory research, there is actually a continuum of participatoriness. So, and I think the idea here is that the offer is made to the community to be engaged in the way in which they want to be engaged and are comfortable in being engaged. And it doesn't mean necessarily that you're forcing people to sit down with you at every step of the way, because oftentimes, especially as trust is built, the community will say, you know what, I don't need to be involved in that part. You go ahead, I trust you. And so there's going to be different levels of involvement in different projects at different points of time. Reciprocity is super important, and again, it's to acknowledge up front that both the researcher and the community are benefiting. Because of course, as much as this work, I do this work because I have to, because it's important, but of course I'm getting something out of it, and I wouldn't deny that in terms of my whole career. And so it's acknowledging that and discussing and talking about expectations and being open and upfront and making sure that what people need to get from it, so both parties, the community and the researchers, those needs are met. And then responsibility, so it's very sort of the umbrella concept of that regroups all of the R's. And it's to say that you're going to do things in a responsible way. We often hear the phrase, in a good way. And there, of course, are many challenges to doing this, as you can imagine, and it's pretty intensive, it's very engaged, it takes a lot of time, it takes a lot of resources. You need to talk to a lot of people. There are different governance systems in different communities, and so the first thing you need to know is who do you need to ask and who do you need to talk to, and you might have several layers of consultation that would need to happen, and that takes time because this is about relationships, and relationships take time. Sometimes there can be turnover in personnel, and so that can be difficult because when you've established that relationship and you have something good going and then that person leaves, you're kind of starting from scratch again. Can be community unfamiliarity with the research topic, but then the onus is on the researcher to help bring people up to speed. Just as on the other end, the researcher needs to be brought up to speed on local community customs, policies, ways of working. And so there's an education that has to happen on both parts. And then, of course, there can be conflicting expectation, conflicting priorities, timelines. I mean, I know that from the research perspective, we're seen as being very, very slow in terms of actually, by the time we analyze our data, sometimes the community's moved on to the next program, right? And so some of those timelines don't always mesh, but we do our best. Now, of course, there are lots of advantages, and that's why we continue to do this. For the community, it's the power to determine research priorities and to say, no, this is what we need to know here. And this is, our priority, and this is what's most important. And then they can also tell you what resources are available to do that. And it can be very locally tailored and relevant to that context. There's always, we're always very conscious of building research skills among community members, and we involve community members in different aspects of the research if they want to be involved. And on the other end, the researchers need to come up to speed in terms of cultural safety and cultural competency and understanding the history. And so everyone's capacity is potentially built up through this model. Locally, projects often create jobs. The sustainability of research outcomes is enhanced because the community is part of the process and they have ownership. And so it's much more likely that once the research dollars dry up, that the project, the initiative, the intervention at least, maybe not the research, but something will continue to live on. And the Kahnawake model that you're going to hear about in a moment is a testimony to that. The advantages, of course, again, incorporating local knowledge. And that's super important to interpreting any kind of findings that you may have. Your data are, not interpreted within context are actually a lot less meaningful, not only to the community itself, but to the research world. And responsibility is shared by all of the players, so that's community and the researchers. And what that means is that we also have a duty as researchers to feed back all the results of the community first and foremost, before anything gets out of the community. Because any information that it is about them needs to be vetted. And so what that leads to is we actually increasingly researchers are working with communities under what we call the OCAP model. And the OCAP is ownership, control, access, and possession of data. And that's, it's a First Nations document, but that states that all data will be owned and controlled by the community. And so what that means is that as a researcher, even if I have a CIHR-funded project and I'm the PI, that the data do not belong to me. And that if I, in a few years, want to go back and there's a new question that could be answered with this, I need to go and ask the community and get the proper permissions for that. And so ownership is that the community owns the information. Control means that they decide who gets to use it. And access is also being able to say who can who can have it, no matter where it's held, because sometimes it won't necessarily be physically in the community, but sometimes it will. But all the permissions run through the community, and possession, again, as I said, can be in or out of the community. There are similar guidelines and models for Métis health research. There's a lot of overlap between these documents, but I just wanted to recognize and acknowledge that they have their own guides, as do Inuit groups who work with researchers. And again, there's a lot of overlap, and essentially it's the same ideas of control and possession of data, and just recognizing that that it is theirs and not the researchers'. So a lot of these documents have come out of and sort of all sort of came at the same time in recognizing that if we're going to do research with Indigenous communities, that this is the way it needs to happen. And so CIHR actually published specific guidelines for health research with Indigenous communities. And the Tri-Council Policy Statement 2 actually contains a standalone chapter, Chapter 9, for working with Indigenous communities. And so if you were planning on doing that, then that's something that you definitely need to be aware of and you need to consult. And in the middle there is the logo for the Kahnawake project, which was actually very pivotal and almost pioneering in this approach to research ethics, and actually informed a lot of the CIHR documents. And this was a document that the Kahnawake project, when it started, sat down together and crafted, and in order to create the foundation of how the academic and the community researchers were going to work together on diabetes prevention in that community. And it became a model for all of Canada and beyond. And so I just want to acknowledge the funders that have funded us over the years and in most of our work, and to thank CSEP for allowing us to share our work here. And now I'm going to pass it over to Alex McComber, who will give you an overview of how now all of this gets applied and translated into diabetes prevention programs across Canada. Thank you.
Push the green one, okay. Kanjoko, otsedoga Alex McComber yujats, diskarewage, danoro diskaragete, ganyakahagen, ganawagadono. Greetings, everyone. My name is Otsedogo, Alex McComber. I'm Bear Clan from Kahnawake, Mohawk territory, which is way out in the east. Way out in the east. How to get over those mountains. What kunuarado sego suaguego. Skana got nigurio gasistansere suaguego, gananunquatsere suaguego. So I extend to everyone here greetings of peace, of a good mind and of knowing our responsibilities and the strengths that we carry, and remind all of us that we carry those things. I also send a greetings of love to everybody here in the room, because we're all connected with that love as human beings, and also then connecting with Mother Earth and our life that we have. Skana goa dana goa ganjokwa dana raksutayawari dana aksutayawari Conception Torono dano Laguangarono Gasastansene Yetinistagio and Zade. So we give a greetings to the people and the old ones who of the nations on whose territory we were meeting, and we thank them and are honored that they continue to carry on the ways and spirit to protect this land and take care of that. I'm going to be all over the map today, and so I just want to maybe advise everyone to fasten your seat belts. It'll be a bit of a bumpy ride. There's lots to say, and thankfully my colleagues here have covered lots of these points. It makes it a bit of a challenge to then come around and say, okay, well, I said that, I was going to say that, he did that, she took that away from me, and figure where we're going to go with this, as well as going beyond just providing a case study of the KSDPP model, which Lucie had referred to a couple of times, and bring something broader, pulling the lens back from the specific to the general of things that are happening in this territory known as Canada, which is a Haudenosaunee word. And so I would like to start with a reminder, or maybe a hearing for the first time, of who we are. And the Concepcion, the Leguangan, the Haudenosaunee, the Lakota, the Innu, the Cree, we come from the same source. And we have our creation stories, which tell us from where we come and who we are, why we're here. Our creation stories, our mythologies, our legends have informed us and provided us with this knowledge that we're spirit beings on human journeys, that we have this intimate relationship with our life, that we're a part of a circle upon which we're dependent to live, which includes our mother, the waters, all the things that grow, our relations with whom we share this planet, and our skyworld relations, not only around Mother Earth, but then across the universe in those four directions. And we're all connected together in there, and that traditionally, pre-1492, that the peoples who existed were in one and came from a time and lived in a place of perfect health. Everyone was healthy, everyone ate, or everyone went hungry. There was no jails, there was no police systems. People could do great and amazing physical feats, and had a science and ways of doing that are unique, that were unique and still are unique today. And this is documented by the missionaries, and I put that out there just so that with the Western thinking mind, that there's a validation to that. The missionaries wrote it down, so it's true. I'm not making this stuff up. But I'll also come back and tell you that that's true because that's what our grandfathers have told us. And they learned that from their grandfathers and grandmothers. And they don't lie to us. Grandparents don't tell us lies. And so what they've been passing down for these millennia comes from our foundation of knowledge. That's valid, that's true. And because we know that, and that carries on in our language in ways today that we know that it's true, and we're at a point now where we can stand up and look back to the academy and say, and it's true because we're telling you that way. And that we don't require numbers and scientific methods and these other Western methodologies to prove that. And it's not knocking that. It's not about knocking that, but it's about beginning to understand that there are different ways of knowing. And our ancestors carried that. And it's there, and it's still there in spirit and in time, and it comes back at these times when it needs to come back. And so we'll roll into that a bit. So just to explain that foundation, that up to 1492, we lived in this perfect world, and all this that we had was pretty awesome. But then through the traumas that both François and Lucie touched upon, impacted. And it was more than just a 1-2 punch. It was just one thing after another, everything including the dogs biting at your ass as you're running down the road. And it's a process that took peoples and flipped their lives upside down, of which we only get inklings of as human beings today when a trauma hits our family, or we're impacted by something like 9/11 and those towers coming down, or by the earthquakes or tsunamis that kill hundreds of thousands of people. And so we can understand the impact of those things. So imagine nations of people from that time of contact within 50 years having an entire world turned upside down. And it comes to then a time where we can say, well, that's it, game over, we shut down, or we realize that through all of this, that the languages have continued and the cultures and ways have continued, and these teachings and understandings, those things that I talked about a few minutes ago, are still there. And so as human beings, we're resilient, and there's a reason for this. And it goes back to understanding those original instructions and who we are and from where we come. But all of this has created in our societies this ethno-stress, and that because we're Angwahunwe, the original people who live in spirit, that's what we call ourselves, the Anishinaabe, the Dene, we all have our words for describing the collective of who we are, that we've been battered and pounded by these stressors, and it creates there's an outcome of that, and it's what we see today, and we've seen for the last 100 years in the history books and in the media particularly, and more of the reality of being an Indigenous person living in Canada in the 21st century, whether it's in a remote flying community or it's downtown Winnipeg and every place in between there. And it impacts and creates stresses of an amazing magnitude that we scratch our head and say, wow, it's crazy, how are we still standing here? But we are. And in standing here and in doing these things and remembering the things that our ancestors have told us and taught us, it gives us strength, and we move things forward. Okay. We compound that legacy of historical events with the impact of the social determinants of health onto our lives, because we're now trapped living within a Western Canadian structured society, and we are the, pun intended, low people on the totem pole. We then have these things that we then have to go look back to understand where have these problems come from, so how do we go about to fix these things? So when we work in health promotion in this time, it's more than just doing the planting a garden experience in a community, or going back to the bush, or getting a lacrosse team or a moccasin club walking program happening in the community to change things. But that we also become environmentalists, we become politicians, we become sociologists, we become mental wellness people as well, in trying to find the solutions in this rushed time, because François talked about those young ones that have been afflicted with this diabetes at 10, 12 years old. And the work of Dr. Heather Dean in Manitoba has a rich body of information that we look and understand and say, how can we let this continue? How do we change that? And so those become some of the things that motivate us. And so we end up with having this diabetes, which we put a little equation in empowerment workshops that we do, and we talk about that unhealthy eating habits and no physical activity and living in a world of stress with a negative attitude makes us sick. And so the message actually that we promote is healthy eating habits, daily physical activity, and managing our life in a good way, walking with the journey with a positive attitude is the answer. And we can take a bow and say, thanks all for coming, just go out and start to do that. And we know that each one of those things is this ginormous topic that needs to be addressed by so many people in so many ways to work around that. Jumping through, Canada is right up there in the, we've got the statistics for the, the Hall of Shame, being, among the countries in the world with the highest rates of type 2 diabetes. The reporting of overweight, obesity, and relationship with diabetes has been said among Indigenous peoples, so we can narrow it down by the surveys, whether it's a regional health survey, First Nations on Reserve, or the other study that was done with Native people living off reserve, or Métis data collection, et cetera, tells us that we've got these problems. It's high. Complications with that, there's not just one. We got high numbers of 2 complications and high numbers of 3 complications living with the disease. Details of what actually people are feeling and suffering from. Just putting out the marker there that, it's a big mess. It's a big mess, and then we have to come along in our health promotion efforts and try and work our way through this. And so for the balance here, share with you examples from a whole array of experiences that we've had over the last 30 some odd years in Canada in dealing with this war against diabetes, fighting it. And Lucie mentioned one of the Indigenous worldview values that we carry. We keep in our mind, the face is yet to come. We do these things for the grandchildren of our grandchildren, because the grandparents of our grandparents set things in motion by what they did for us to have this. And so we're in this slump, and so we work to get out of that. So organizations like the National Aboriginal Diabetes Association have been formed, located in beautiful downtown Winnipeg, which is about addressing diabetes among Aboriginal people, creating networks, opportunities, and resources that will emphasize Indigenous values, beliefs, and traditions. It started in the 1980s with a group of Indigenous moms in Winnipeg that were fearful of what diabetes could be coming to their children and doing. They saw it afflicting the adults. And they formed a sugar group. And from there, within 10 years, the National Aboriginal Diabetes Association was formed. You would think Canadian Diabetes Association, you hear that and say, oh, we know that that's a well-funded, extensive national program with offices in all the provinces and all the major cities, et cetera. And you would think that, wow, that's a really cool thing, something that, NADA, if I hear NADA, that must be like that. Well, it's a little 2-person operation now in a hotel, in an apartment in downtown Winnipeg. And for these years, having been a part of that in the past, we've been this lobby effort to collectively keep the information not only in front of the people of our communities and raising the awareness, but also working with government, working with agencies to not only keep the profile high, but educate those people as well as to what the realities are. And so in partnership with the, excuse my old man's brain here as it shuts down. Not the Truth and Reconciliation Commission and the Royal Commission. The Royal Commission, that was the one after the Oka crisis, 1990. We were talking about that. That they put out. We go back to these documents where we realize the problem that's happened and that these efforts have to come forward. So lobbying at a political level, at an economic level, at a social level, even with the fewest number of people on a staff and a board of people and those of us that are members of the organization, put the word out. It becomes more of a moral responsibility that these are the things that we do. And so we mention this as a very important activity that's been going on, and so NADA has produced information that then goes to community diabetes workers in the form of pamphlets and little education packages, now videos and things like that, as well as lobbying on the stage when it looks at government when government looks at new funding and new programs coming up, to make sure that the lobby effort's in there. And as well as brokering and being a part of the partnerships between community and the academy, and learning how do we do things together. The main partner from government when it comes to diabetes has been the Aboriginal Diabetes Initiative, which actually was given birth in the Fort Garry Hotel in February 1997. I was there. And it wasn't in a hotel room, it was in a meeting room. And 5 successful NHRDP research projects, 3-year projects working in our First Nations communities. One of them with the Haida Gwaii up at the Queen Charlotte's. Got tremendous positive response from community right away, bringing new ideas and programs about fighting diabetes, coming from a partnership between community and academy, asking the community what would they like and how would we like to go about doing it within each of our different project parameters. And we created partnerships, and we began to see some quick results of people's awareness about the dangers of diabetes and the importance of healthy eating and physical activity were. And by 1997, when those grants were going to be finished, we gathered together with Health Canada and with the Canadian Diabetes Association and with NADA, and we met at that hotel, and we said, okay, this has to continue, because we certainly got direction in Kahnawake from our community advisory board at the end of 3 years. You can't finish. You have to keep going on with the work that you're doing in the schools and in the communities. Even though we may not have seen major results in data collection from fitness or lifestyle changes in elementary school children, we certainly saw definite trends, and there was optimism given to parents and people in the community of doing something to begin preventing the disease. And so from there, the Health Canada and FNIB, First Nations Indian Health Branch, or Indigenous Health Branch as it's now known, agreed and did the lobbying and all that politic government work to create an Aboriginal diabetes strategy, which then morphed into a Canadian diabetes strategy, and it became an Aboriginal diabetes initiative. And this becomes the main government source of government funds to support intervention activities in communities. It goes on 5-year increments, and finally last year has been declared as a permanent program within FNIB's hierarchy to the tune of $58 million a year or thereabouts to service over 600 First Nations communities and the populations that are around there, as well as smaller amounts of money going to the off-reserve urban and Métis populations. So while it's a big effort and it's important, it still becomes a drop in the bucket when we do the math and look at the things that need to be addressed. And we've certainly learned that we started out with healthy eating habits and daily physical activity, and how that's just evolved to talk about stress management and talk about working from depression, and particularly in the last 5 years, beginning our process of healing and decolonizing and regaining strength as Indigenous nations. And we know and we learn that this is where our answers lie. Just a look here, where you see that there's over 600 communities and getting primary prevention activities through the Aboriginal Diabetes Initiative of Health Canada. There's 300 community diabetes prevention workers. So that just half of the First Nations communities, meaning the reserves, have a diabetes worker in the community. So while it may be a great effort, not to knock my comrades at the ADI, who so many of them do some great things, when we pull that lens a little bit further back and look at that larger picture, and we see that it's a drop in the bucket, and so that the work that we do is that much more difficult. The resources are stressed just for that. But through it all, we continue to gather. We continue to share the experiences that we have, whether it's the lunch bag program in the schools, or the after-school walking club, or the powwow dancing training, or the 2 weeks in the bush camping experience. Sharing those things, as well as the research and other opportunities. We do what we can because we're all saying, even though Ladigusa Daje is a Haudenosaunee thinking, other nations have their own language, their own words for saying that, yes, we're responsible for our future generations. and to help our peoples today. On a national research level, for quite a while, there was a National Aboriginal Health Organization. The Indigenous research think tank for First Nations, Métis, and Inuit people, which then lost its funding. And went down. So as good things were coming, and of course going through struggles and learning how to collaborate and work together with communities, with the academy, it then eventually did get shut down. But the OCAP guidelines that were born through there remain strong today and become this important piece that when we talk of the relationship between the academy and the community-based participatory research stuff, that those kind of guidelines become so important because it gives the communities power and responsibility for the data and the processes and things that are being done, and that knowledge is power. And sometimes that power may not translate right to the grassroots level in the communities, but if it starts to get into the health leadership within the community and understood by the band councils within community, and if the academy begins to understand that process and that things have to change, then it makes headway and things trickle and produce some better results. One of the CIHR children is the Institute for Aboriginal People's Health. And some of the studies and works that have been in there around diabetes surveillance and diabetes prevention are bridging gaps, knocking down silos, and bringing different Indigenous communities together in partnership, again, with the universities to understand what the community is needing and wanting as far as then working with the people who are dealing with diabetes in their communities. The Youth Mentorship Program, which is just launching now through John McGavick at University of Manitoba, and we have a pretty wild team of researchers from community and from the academy and working with 9 communities across Canada, of teaching teenagers about healthy lifestyles and about running workshops, and those youth then create after-school healthy lifestyle programs for grade 4 children, with positive results for the children that are attending the program and positive results for the youth, those teen mentors, not only in areas of awareness of fitness and healthy lifestyles and food choices, but also of self-awareness and leadership skills that they carry. So this is an exciting project that's just getting off the ground now and has had success with 3 communities in Manitoba. 5 communities, I think? Yeah. 5 or 6. So now we're bringing it out larger. So these success stories are coming with the partnerships of people talking together with the two-eyed seeing thought, with the ethical space that Willie Ehrman talks to, where the Western science and the Indigenous science comes together, and in that center area we have that respectful dialogue and understanding with one another to learn new things, and it becomes so powerful and so important for us to get a hold of. Other national efforts include the Inuit Urban Diabetes Prevention Awareness Program. The Right to Play program has a focus working with Aboriginal children or Indigenous children. The Canadian Diabetes Association and the Everybody Gets to Play program in the past have had programs that have supported work happening with Indigenous communities, particularly in prevention. At a regional level, we're seeing associations of First Nations because they have their political lobby groups, bands working together within each of the provinces. There's also generally a health secretariat that comes with that. And the First Nations of Quebec and Labrador is one example of that branch just really doing lots of work. And the challenge in Quebec being that there's 11 different First Nations, and 7 of those First Nations are Francophone. So a Francophone and an English Indigenous population working together, having to work together, learning to work together, understand and sharing, and doing the kinds of programs that then trickling back to the health directors and the community workers, finding what are the things that are working and sharing those things with one another, whether it's written resources or whether it's hands-on activities, and in the areas of the nutrition, eating habits, physical activity, managing stress, et cetera. The BC First Nations Health Authority in this region is a new group that's taken a lot of work. I'm just learning about the detail of the structure and the efforts that the participants are doing to make it as a flat and collaborative process as possible for getting diabetes education and knowledge and support back to communities out here. And the Southern Ontario Aboriginal Diabetes Initiative is an amazing program out of Thorwald, Ontario, with 6 regions and diabetes health leaders in each of those regions, offering and facilitating and mobilizing within those regions all these different kinds of activities and fostering the communication. And then they've also expanded now into the northern regions of Ontario as well. Education programs such as at Yellow Quill College, First Nations Technical Institute are around educating people to become workers in diabetes programming. Particularly the FNTI experience has a heavy influence of Haudenosaunee or Iroquoian or Six Nations philosophy, teaching, worldview, and practices in there, because that's within our traditional territories. And looking at health from a different perspective, looking at what do we want and building things positive and getting a better understanding of the things that have happened in order to find solutions and not to cry about that. And our experience in Kahnawake has been quite an honor and quite a roller coaster ride to have been a part of these past 22 years of doing primary prevention with the elementary schools, moving into the high schools with the community. And it's about passing on information, developing skills, working to build supportive environments, building partnerships, helping adults, parents, teachers, and grandparents understand that they're role models and that they need to be healthy role models to support those children. Our examples is our example, and François had the chance to work up at Sandy Lake, where Stuart Harris and the gang there have been doing long research and work in community mobilization. And so towards the wrap up here, then just kind of hitting some of the some key things to you as important messaging that we work hard to get across. Changing the language and stop using that word diabetic to describe me as a man who's dealing with a disease. I'm a man, I'm a father, I'm a husband, I'm a grandfather, I'm an uncle, I'm a coach, I'm a ball player, I'm an honorary doctor. Don't call me a diabetic, because if you say that to me or you say that to your grandmother or that patient you're working with, you're giving that power to that damn disease over the human being. And so we work hard to educate people in community to say, don't call yourself a diabetic, because we're more than that. And so that's an important, and that's connecting us back to who we are as original people, as Indigenous people. We have to remind ourselves of our relationships with our families, with our communities, but most importantly with Mother Earth and all nature, that we're part of that we're one with that. And it's a different kind of thinking. It's not a top-down. It's not man ruling over all the earth and all the women and all the creatures in the sea, etc., as the Bible says, but that it's a circle, and that in that circle that we respect and honor all that life in the circle, because we are all the same. And that these are then healing strategies. Cultural-based activities, and moving away from the pan-Indian powwow. Everybody does a powwow, everybody goes to a Sundance, everybody does a sweat lodge, everybody's got a dream catcher, to the things that are unique to each of our nations, because that's our roots, that's from where we come. And so we learn to do those things, and in there we gather our own strength and we gather our own healing. Education continues to have to be in front, not only about the disease, but about those healthy eating and ways of healthy things, and doing those healthy things, as well as understanding the crap that has happened, and I'll dare say it, that we have to get over it. And we have to get over that. And certainly you understand, and please understand and appreciate that when you go to a community or when you go and tell an Indigenous group, you people have to get over it. That, yeah, those are words of war. because the individual from outside is the representative of the colonizer and the oppressor. But I'm saying that within our own communities, we are starting to say that to each other. And that's what we need to do is find our own voice and our own strength in there with prevention activities. And so it is about empowerment of an individual. It's empowering a child to be healthy. It's empowering an adult to be dealing and living with their diabetes and fighting that. And in order to have those healthy lifestyles, it means being political, it means being social, it means being spiritual, it means being environmental, and it means standing up for what we have to stand up for, because that's our responsibility. That's what we've been given at our time. And we do this for our families, our children and grandchildren, our elders. I introduced you, that's my family right there. That's the whole gang. That's all of us. And so that's why I do that, and that's why all of us in the business do that for our families, for our elders, and for the future generations. Hey, how you like that? So with that, Goa, thank you very much, merci beaucoup, for your time and attention with this presentation.
I was at a conference 2 weeks ago on ketogenic therapies, and there's, his name is Mark Mattson. He's one of the leading neurobiologists in the world. Said there's a cure for type 2 diabetes. And to paraphrase, it's the traditional First Nations diet, which is in the merging that Alex just told us about of traditional knowledge and our knowledge, we just call it a ketogenic diet. And I've worked with First Nations. I have family in First Nations in BC and the Yukon. And so here's a little story. I went to my father-in-law, who's very healthy, hale, hearty, in his 80s, and does the trap line every day. And I said, what do you eat? And he said, I eat fish, and I eat moose. And I said, yeah, it's great, from the land and so on. And I said, what else do you eat? Do you eat anything else? And he said, yeah. And I said, what else do you eat? And he said, I eat more fish, and I eat more moose. And I said, do you eat, vegetable? In western BC and in the north, where people eat a traditional First Nations diet, they don't get obese. People don't get obese. They don't get diabetes. They don't get cancer. They don't get cardiovascular disease on their traditional diet. When we bring our food in, which is part of the colonization we've talked about, I think that's the root cause of much of the chronic disease. But in there lies the solution, which the First Nations have known all along, because they say the forest it's our pharmacy and it's our grocery store. So, and I'm biased because I study ketogenic diets and I think they're very healthy. But I wonder, to go back to the question, what are the challenges in encouraging that sort of traditional diet, which I think is a much healthier diet for First Nations peoples, on reserve in particular?
I mean, that's definitely the question, because what you're describing there is really what we're hearing throughout every community. So what I kind of showed was the challenges of getting off-the-land foods, and it's very present. That challenge is there. But one thing that also has to be understood is that not all store-bought food is bad. So part of the strategy is also improving, because one thing you got to wonder about, is it possible to live entirely off the land? So if you think about every environment in Canada, what I'm seeing in Telegraph Creek, where salmon are migrating in, getting fish. So I was asking one of the fishermen, how much does it cost you a year to get 300 salmon per family? He goes, $125 of gas, because they can net them right at the community, and they can net as much as they want. And I was part of that. I actually spent 4 days catching salmon with them, and it was insane. Like, honestly, compared to anything that I've seen in First Nation communities of Northern Ontario, not comparable. But in First Nation communities of Northern Ontario or Northern Manitoba, they were semi-nomadic people that we forced onto reserves. And that made it very difficult. Even though food was being provided, the quality of the food being provided was not very good. But the strategy to live off the land was not a sedentary, community-style, reserve-style way of thinking about it. And when you talk about the elders, that whole concept of maintaining a food system with a static environment does not make sense. It's very difficult for them to sustain the calorie needs if you cannot follow the food resource. When one lake is depleted, you move on to the next lake, because it's one lake after another in these communities. But as you go along, the food availability becomes further and further from the center. And anybody that knows about foraging strategy with chipmunks, there was Kramer in McGill that used to do these studies about foraging strategy. Well, when you're foraging off-the-land food, it's a foraging strategy. And the cost of foraging is becoming greater and greater and greater. And one thing that I'm just going to mention about contaminants, most of the contaminants are locally produced. So they're not coming from the south, they're actually coming from the communities themselves, which when the message was given to some of the communities, the elders stepped in and said, we told you guys to stop putting cars in the lakes, to start throwing engines in the lakes, and anything you didn't want to see to be thrown in the lake. And I think what it did is it pushed people further and further away from where their food resource was. So there's a lot of changes that need to occur to live off the land. Of course, that food is great. I mean, it is very important food, but we cannot exclude that store-bought food can also be improved.
And so I'll just add on there that the people at Akwesasne did not build the GM plant that was upriver from there that up until recent times, poisoned the fish in the land. So it's a combination. There's no denying what you're saying, but we do have to look broader. Jotted some fast notes down here. People have to relearn that knowledge, not only of the foods, but of the way of doing it. 1994, when we started with KSDPP in Kahnawake, there were hardly any people that ate squash. Squash is one of our three sisters, one of the life sustainers. Now squash is at all meals, is at lots of community feasts and ceremonies, and back into the regular diet. So we have to teach about the foods, and we have to learn, and also from those elders and from the people who know about those foods. We have to care for the land. The land has to be taken care of, and it's a collective. We certainly have to do our efforts within our communities, but also then have to advocate. And that big challenge is when you're dealing with pipelines and the Ring of Fire and these other giant projects that rape the land. That deals are cut with First Nations communities because it's going to give jobs. And jobs means money, and money means that I can then put flour and maybe a little bit more than flour or some of that, $90 roast on the table. Understanding the relationship between people and food is important. And so now we're going into values and understanding our traditional values, because that relationship that we have with food is sacred. It's ceremony. Whether we are hunter-gatherers, agriculture people, fisher people, our ancestors had that relationship. And I'll just share the story with from Norma General Cayuga, faith keeper, in teaching a course on nutrition. And she says, when we see or smell or hear that food that's getting ready, our first reaction is that we salivate, our mouth salivates. She says that ceremony, that's the spirit and energy of our body, knowing that that food is coming to visit us, that it's bringing its gift to us to have that, and that's the first preparation that our body does. And the biologists all say, yeah, that's the enzymes and stuff that's going to begin that digestive process. And so we know that food, and so our ceremonies, our harvest in midwinter and strawberry and Wata festivals and ceremonies are all about honoring that. And other nations have those ceremonies that honor the salmon or honor those animals, and you put your tobacco at the forest or at the water before you go in. Not just as a Hollywood mumbo-jumbo kind of thing, but you're truly giving and bringing yourself and introducing yourself in that best way that you can. And talking to that forest and talking to that moose and those energies out there to say that why I'm here. And when it's meant to be, those paths are going to cross, and you're going to bring home that food for your family. And so there's that cultural connection that has to be retaught and relearned and shared within our communities, again, of actually doing those practices over time and using those thoughts and words until it becomes back as this is what we do. And this is how we do it and why, and it's a natural thing.
You can see that's a very important question. So I'm just going to add one thing to it, because if you think about the grassy narrows example, people can develop the best food system possible, but within one incident, everything can go down the drain. And when fish was so important, it was a staple food for that community, when it's contaminated by an industry, everything went down the drain for decades. And that's how fragile that environment is. And in some communities, people are on committees and follow on government committees to make sure that they know exactly what's happening to the environment around their community, and they're involved in policy making, and they're involved in advocating for change. And that's very important. So that's how complicated it is to live off the land. It's amazingly complicated, whereas it might have been a bit simpler before. It was still difficult, but simpler in terms that there was less interaction and you just had to deal with season and seasonal changes. Now there's all these additional factors of industry that comes into play.
Well, thank you very much, everybody, for coming. I want to give a little gift to all our speakers, and they're here for a little bit if you want to ask some questions. I have some burning questions about the long-term evaluation of Kahnawake. So you're welcome to come up and catch them during the conference, and other than that, thank you very much.